My name's John Hayes. I'm one of the founding cardiologists of the Queensland Cardiovascular Group. I'm specifically a cardiac electrophysiologist. My area of expertise and interest is in cardiac rhythm management, devices and ablations to try and cure arrhythmias. Atrial fibrillation does have a number of issues associated with it beyond the symptoms. Because there's rapid chaotic activity of the atria doesn't contract and pump the blood properly. Blood can stagnate, that stagnant blood can clot, and those clots can then break off and travel to any part of the body, potentially kidney, arm, leg, or the brain. So one of our greatest concerns for patients suffering atrial fibrillation is their risk of clots and strokes. The other problem with atrial fibrillation is that if it was left uncontrollably fast for prolonged periods of time, potentially months at a time, that can lead to weakening of the heart and heart failure. So when we think about patients' management with atrial fibrillation, we address a number of issues. Clearly, one of the paramount important issues for us is the risk of clots and strokes. So we do look at anticoagulation to thin their blood, things like warfarin that many people have heard of, or some newer agents that replace warfarin and are more convenient, not requiring the regular blood testing that many people are aware of with warfarin therapy. So once we've established that they're safe and reduced risk of their clots and strokes, we can then look at addressing the rhythm itself. Atrial fibrillation has a number of management options. One of those would be simply controlling the rate so it's not too fast, doesn't weaken the heart, and doesn't lead to heart failure. In some people who are not particularly troubled, that is, they're minimally aware of their atrial fibrillation, simply controlling their rate, reducing the risk of strokes may be all that is needed in their management, and they can get on with a totally normal quality of life. When patients present with atrial fibrillation, it's important to assess whether there's any underlying heart disease. Atrial fibrillation does become more and more common simply with aging, but it is more likely if we have any heart disease. That might be viruses affecting hearts, rheumatic fever, valve problems, blocked arteries, heart surgery. Sometimes it's related to non-cardiac issues, obesity, sleep apnea, too much alcohol, thyroid disease. So when we meet people with atrial fibrillation for the first time, it's important to screen them for any underlying cardiac or non-cardiac disease. If it is just simply atrial fibrillation and there's no underlying structural or functional heart disease, that puts it into a different management strategy to if they have underlying heart disease, which may need treatment on its own merits. Some of the best candidates for an atrial fibrillation ablation procedure would be the younger patients whose atrial fibrillation still comes and goes of its own accord, what we would call paroxysmal atrial fibrillation, and in particular those whose hearts are otherwise structurally and functionally normal. The more persistent atrial fibrillators, those that may have underlying heart disease, valvular problems, they may stay in atrial fibrillation for years at a time, are more challenging to help with these ablation techniques. But we can certainly look at those individuals. I think the most ideal patients would be the younger people who continue to have atrial fibrillation, particularly despite a trial of antiarrhythmic therapy. It may be proving ineffective, they're still getting the atrial fibrillation despite trialling one or two different antiarrhythmic medications. They may have side effects from those medications and not tolerating it well. These would be the ideal candidates to refer for an atrial fibrillation ablation procedure. They are invasive procedures, but they are done through minimal or keyhole surgery with little incisions in the groin, and it's done as an overnight procedure. Patients come in, we tend to do it under a general anaesthetic for their convenience and comfort. It's not absolutely necessary, but I find it very convenient and preferred by most patients. We stay in overnight on some medications and then go home the next morning.